Welcome.
This is an anterior wall STEMI bailed out by a step mini crush. So this story is of a 54-year-old gentleman who came at 1 a.m. into a hospital with 4 hours chest pain. He had been having effort angina for a month. Stress test was positive, and angiogram done elsewhere had shown triple vessel disease, and he was awaiting surgery. He was a smoker, and there were no other risk factors. So we did a ECG that showed some deep T inversion in all the leads, some little bit of ST elevation, V1 to V3, and we took his echo. This shows predominantly anterior wall, regional wall motion abnormalities with no inferior wall.
Our emergency department loves Wellens waves. They love to say Wellens waves, but remember, Wellens first described that with the LAD open. It's reperfusion, so I get to go back to sleep when I see the Wellens waves. Nice happen in the morning.
So we did a transradial angiogram, showed mild RCA disease and significant left system disease. So we went ahead with the femoral approach. We took a 7 French EBU catheter. As you can see, the guide is not sitting well. It shows about 60 to 70% distal left main disease. LAD is sort of occluded at the proximal segment, critical diagonal disease. So we wired both the LAD and the diagonal, and we got some flow through, and we started predilating the LAD from the mid segment. So the issue is whether we need to do a stenting for the diagonal or not. So we know that when it's a large side branch, it supplies more than 10% of the myocardium, it's better to stent it. So we decided on a 2-stent strategy. Also from SJ Path series, we know that when there's a Medina 111, 011, or 101, it's better to stent. So we decided to go ahead with the left main stenting because left main at 70% stenosis. And the goal is to perform PCI safely, prevent complication, and reduce TLR. So we went about predilating the LAD first and the left main with 2x15 semi-compliant balloon. And then we got some slow flow in LAD, which is expected because it's an MI. So we gave some intracoronary nicorandil and sodium nitroprusside, and that improved. And then we found there's a lot of dissection in the mid segment of the LAD and critical diagonal disease also, probably extending about 5 millimeter from the ostium into the proximal segment. So we thought we'll anyway go ahead with the 2-stent strategy, started opening up the diagonal with a 2x15 semi-compliant balloon. Then we positioned a 2.515 drug-eluting stent in diagonal, and we pulled it back just to the ostium of the circ, and we put another 3x15 NC non-compliant balloon from left main to LAD. Then we deployed the stent, and then we removed the stent balloon and then crushed the stent with the 3x15 NC balloon from left main to LAD. Next, we started stenting from mid LAD onwards. We first put a 3x23 drug-eluting stent in mid LAD, and then overlap stented with a 348 from left main to LAD, overlapping the first stent. Then we recrossed the diagonal with a run-through wire, and it was a little difficult to get into the diagonal. So, but we managed with the run-through wire, and we opened up the struts with a 1.512 balloon, and then we did pot for the left main and LAD stents because it's easier to push larger balloons across when you do pot. Then we post-dilated with a 215 NC balloon at 20 atmospheres. And then we did, then we did again one more pot. And then we put a 2.5 15 NC balloon in the diagonal. And then 315 non-compliant balloon in the left main 12 LAD stent. And then we did simultaneous kissing balloon. And then once more we did a pot with a 3.5 15 non-compliant balloon. So we thought things are okay and we can get out of the cath lab. So again, just to reiterate that when you do pot, make sure that the distal end of the balloon is just at the carena, so that when you dilate the balloon, the struts open towards the circumflex, so it's always easier to recross. So then we found that this some sort of crowding of stent struts and some haziness at the left main ostium. And we knew we had got this longitudinal deformation of the stent due to the guide. So we post-dilated with a 3.75 15 balloon. And this is what happens actually. Longitudinal deformation happens when you have a balloon pullback or when you have a jail wire pullback, especially seen with EBU when it goes and hits the stent. So ostial lesions, calcified lesions, left main lesions are notorious for this sort of thing, and other procedures like when you do downstream bifurcation stenting, when you use IVUS or OCT. So anyway, we post-dilated with a 3.75 15 NC balloon, and we corrected the stent deformity. We got good results. And so it's again, basically this guy had come with, he didn't have shock or heart failure, but we caught him before he went to these sort of stages. And quick, effective procedures with good final results are required to prevent slow flow and early restoration of adequate epicardial and microvascular coronary flow. So you have to use minimum contrast, treat shock, heart failure, and use IABP and Impella when indicated. So again, our patient had a good recovery, and he's doing well.
That's great.
Very nice case. You can't argue with that result. Great result. You said you initially started radial and converted to femoral, right?
Yeah, we do 90% of our procedures radial, but then this guy's radial wouldn't take a 7-front sheath.
Okay.
So we went through femoral.
I see. I think it was a great result, and I think there needs to be some judgment as to what provides you the best support. And you're doing mini crush, and a 7 French is better. But I guess essentially nearly all cases have been done femoral that have been presented. And I think just to provide the message, I don't think that complex PCI equates femoral. Many of these procedures can be done radial. Just something to keep in mind. And either with a 7 French slender or even sheathless can sometimes overcome some of the issues. So, but I think it's a great result.
So we've seen a couple of cases now where some of the difficulty was rewiring the side branch or recrossing across stent struts into the side branch. I personally, though expensive, like to use a microcatheter as the backup for the side branch. Do you find any pros or cons? Is this your practice? What do you guys like to do? In yours. We see you used a balloon here.
Yeah.
I personally don't go with the microcatheter usually, but I have a low threshold to go with a twin pass catheter to make sure that I'm in the main stent when I'm going back into the side branch. Helps a lot. If a balloon is not going in, I try a microcatheter. But in general, if a 1O balloon is not going, a microcatheter is unlikely to go.
Mm-hmm. Mm-hmm.
I would probably start an escalation approach. Wire first, and probably a little bit more with a balloon, then microcatheter, and I would probably say twin pass last. But I think it's twin pass. It's definitely a handy tool in the cath.
I'm actually, in my experience, so after I cross, I go with Godzilla's or Godliner all the way in, then I use the pot, and I take the balloon and get my Godliner all the way to the ostium of the branch, and then of course, and I go with a smaller balloon.
So just so the people in the back can hear the technique the gentleman's describing is to advance the guide liner close to the os of the side branch, advance the balloon in to get a little bit better backup support.
After the pot.
After the pot, yeah.
And that way,
you don't get the longitudinal deformation that we saw here.
And the Godliner go